I'm so pleased to introduce our two speakers today. Deborah Anna Lupnitz is on the faculty of the Institute for Relational Psychoanalysis of Philadelphia. She has also taught courses on psychoanalytic theory in the Department of Psychiatry at the University of Pennsylvania School of Medicine for over 30 years. Dr. Lupnitz is the author of The Family Interpreted: Psychoanalysis, Feminism, and Family Therapy, and also of Schopenhauer's Porcupines: 5 Stories of Psychotherapy, which has been translated into 7 languages and was recently released as an audiobook. She was contributing author to the Cambridge Companion to Jacques Lacan. In 2004, Dr. Lupnitz launched Insight for All, a group that offers psychoanalytic therapy to homeless and formerly homeless adults. She received the Distinguished Educator Award by the International Forum for Psychoanalytic Education in 2013. She maintains a private practice in Philadelphia. Usha Tumalanara, PhD, is a clinical psychologist and the director of community-based education at the Albert and Jessie Danielson Institute and research professor in the Department of Psychological and Brain Sciences at Boston University. Her research and scholarship focus on immigration, trauma, race, and culturally informed psychoanalytic psychotherapy. She is also in independent practice and works primarily with survivors of trauma from diverse sociocultural backgrounds. Dr. Tumalanara is an associate editor of Psychoanalytic Dialogues and the Asian American Journal of Psychology. She is a member of the Holmes Commission on Racial Equity in American Psychoanalysis, initiated by the American Psychoanalytic Association, and serves on the board of the Psychotherapy Action Network. She is the author of Psychoanalytic Theory and Cultural Competence in Psychotherapy, 2016, the editor of Trauma and Racial Minority Immigrants: Turmoil, Uncertainty, and Resistance, 2021, and a co-author of Applying Multiculturalism: An Ecological Approach to the Multicultural Guidelines, 2023, all published by the American Psychological Association Books. Thank you to both of our speakers for being here today.
Thank you, Joanna, and also Michael. It's an honor to be invited. Given that my topic is home and lack of home, it's even more important than usual to begin with a land acknowledgement. I'm able to call this vibrant part of Pennsylvania my home only because others were driven from their homes. I invoke them with humility and great respect. They were and are the nation of the Lenni Lenape. In the 1980s, Philadelphia had one of the highest rates of homelessness in the nation. Now it has one of the lowest. There's still much work to be done, but the progress is notable, well documented, and credit goes to a number of local organizations and countless devoted staff, volunteers, and supportive legal teams. The basic models with which you and this group are no doubt very familiar is housing first. That's what we aim for in Philly, because what the United States needs, obviously, is more permanent, affordable housing, not just more temporary shelters. The risk factors, as always, are the same: unemployment, substance abuse, mental illness. Race is still clearly a factor. So African Americans make up only 13% of the general population, but 40% of the homeless population. In the 1990s, I started to volunteer in the usual ways, serving food, driving in the outreach vans. And I noticed, even in those simple interactions, that my psychoanalytic training seemed helpful. Most people I met weren't looking simply for a sandwich or a dollar. They wanted to talk. A writer named Reynolds Price said it best. I quote him: "A need to tell and hear stories is essential to the species Homo sapiens, second in necessity, apparently, after nourishment, and before love and shelter," close quote. I also found that understanding something about the unconscious, about transference and countertransference, helped me keep my own rescue fantasies in check. This capacity turns out to be a hedge against burnout. So here I am, some 30 years later. Eventually, a social worker asked me to co-lead a group for some women whose residence had been damaged by fire. So I ran the group, and then one group led to others, both for formerly homeless residents and for staff, because staff, as you know, are vicariously traumatized every day. Residents did have access to psych meds at a community mental health clinic. What they didn't have access to was long-term talk therapy. So eventually I sat down with the director of one of these wonderful supportive housing agencies and asked if I could bring psychodynamic, analytic therapy to her organization. She had a lot of questions. She told me point blank she knew two things about psychoanalysis. First, it had no evidence base. Second, it was for rich folks only. She hoped I would not be offended. No offense taken. I told her that I had been taught in college and graduate school the same two misconceptions. So I sent her some articles outlining the evidence base of psychodynamic treatments. And since that time, when we had that conversation long ago, someone named Jonathan Shedler, don't know if you know that name, but he has written extensively, convincingly about the evidence base, especially for more serious conditions. And I can put those references in the chat if you're interested. So as for the question of it's for rich folks only, it helped to share with her some little known history. Little known also, I think, among some psychoanalysts. So in 1918, Sigmund Freud gave a beautiful speech in Budapest where he said, someday both rich and poor alike will have access to psychoanalytic treatment when the conscience of society awakes, and so on. The same treatment for mind as they now have for medical care. That passage of his speech ends, quote, such treatments will be free. Notice, not sliding scale, not small copay, free. Well, the speech wouldn't even really be worth quoting, except for the fact that that was just the beginning. So in the decade that followed those words, 10 free psychoanalytic clinics sprang up in 7 European countries, treating everybody, farmers and factory workers and chambermaids and the unemployed. This story is told beautifully in a book I want to call your attention to. Janica, could we have the first slide? And the book is titled Freud's Free Clinics, Psychoanalysis and Social Justice, 1918 to 1938. And the author is, are you having trouble finding it? Okay. Here it comes. The author is Elizabeth Danto. There it is. Danto. She's a retired scholar, professor at Hunter College in New York. Isn't that a beautiful image? That's Freud with his grandson, and the handsome guy up front is Ernest, one of his sons, who was an architect and designed the building. Everyone wanted to get involved in these free clinics. Artists wanted to have their art hanging on the walls, and people wanted to volunteer in all kinds of ways. So how was it, note the years, 1918 to 1938. How was it possible to staff, okay, we can maybe close that, to staff those free clinics? Well, apparently with ease, because the first generation of analysts had politics, how would I describe it, in kind of comparable to our terms today. They were more or less Bernie Sanders type democratic socialists. See, Vienna of the time already had universal health care in 1920. I mean, they do, Austria does today, as most European countries do, but way back then, they had it. So Freud was simply saying, why can't we extend free medical care, including surgery for all, to psychoanalytic care? So it happened. Now, an important question, I think, is why this history has been forgotten or even erased, maybe. Every undergrad who takes Psychology 101 learns that Freud had this strange idea about penis envy. Okay, everybody hears that. Nobody finds out that he promoted psychotherapy for free for everybody, and that, according to Danto, author of that book, he was more proud of the free clinics than any of his achievements. Here's a bit more history. In 1926, Freud wrote that the least helpful training for an analyst would be medical school. Now, he was a doctor and he wasn't anti-medicine, but he said, the problem is when you go to medical school, you learn to think in linear ways. Let's hope, because if you're trying to decide, is this tumor cancer or not, it's good to think in a linear way. Is it stage 3, stage 4, like that? But if you're trying to understand the symbolism of the unconscious mind, it's better to have a preparation in the humanities, he said, literature, art, languages. religious studies, anthropology. So most unfortunately, when psychoanalysis came to the US, the American group decided to reverse that advice, and only MDs could be analysts. Freud had worked so hard to depathologize homosexuality, for example, and all that was erased. Psychoanalysis in the US became a conservative, homophobic medical specialty done almost exclusively by men because so few physicians back then were women, you see, and very expensive. This was not changed definitively until a lawsuit in 1986. So sometimes I hear feminists of my generation saying, you know, we hate Freud, we hate psychoanalysis. But if I carry the conversation a little further, it turns out that what they hate was this very corrupt version of it, which I also don't hold in high esteem at all, obviously. So, and what about it? Is this kind of very intensive, reflective therapy for poor folks? Well, one could easily ask just as much, I think, does having money make human beings more thoughtful, more keen on the examined life? I don't mean to be churlish about it. I'm just not sure. Maybe it makes us more complacent. I don't know. And I don't mean to idealize poor folks or homeless folks. That's just another trap. Yes. But the old rules about who can be treated in therapy don't apply. Now, back to our story. When the agency director gave me the green light to start a group, I began recruiting colleagues one by one. Can you see one homeless patient for me like that? Can you run one group? So we call our little project of therapists Insight for All, as Joanna said, IFA. There are about a dozen of us active at any one time. And we decided not to apply for any kind of grant funding ever, but to keep things, non-bureaucratic. It works well. We have one member, one psychoanalyst named Violet Little, trained at a very classical institute. And she happens to be our psychoanalyst on the street. She sees only people who have not yet come indoors for whatever reason. She sees some of those folks occasionally and some 3 times per week. And some of the sessions are focused on trying to get better living conditions, and other sessions are just kind of normal therapy sessions focused on anxiety, phobias, family relationships, and so on. But what the rest of us do in Insight for All is individual treatment with people who once lived on the street and have chosen now to live in one of these supportive housing agencies. It is not classical analysis many times a week, lying down on the couch. It is typically once or twice weekly, sitting up. We have had a few patients over the years who have tried to lie down on the analytic couch and they prefer it, but just a few. During COVID, we did phone sessions because luckily when you enter one of these housing agencies, you are given a phone. And so we were able to stay in touch, even start some new treatments during COVID, amazingly. Walking sessions also became common, and I have found them very valuable. One statistic is that the average homeless person walks 10 miles per day. Why? Well, when home environments have been abusive or toxic, indoors is associated with danger and outdoors with safety. Walking also makes it possible to get a meal in one place and clean socks in another, to alleviate boredom, make contact with friends. Our members of our group, IFA, meet together several times per year to discuss clinical issues. Over the years, we've identified several categories or causes of homelessness, in addition to the big systemic ones I mentioned. Talking about the homeless, or even the more popular locution, those persons who are experiencing unhousedness, I find that all a bit distancing. It really can't be improved. The important thing is to remember that natural disasters, for one thing, make us all vulnerable to being home. Hurricane Katrina taught us that. Someone always also mentions the very good fact that there are people who choose to live off the grid, sometimes in tents or in their vehicles, forming a community of mutual aid. Jessica Bruder, in her book Nomad Land, tells this story, came out a few years ago, of people who do this as a kind of resistance to capitalism. And there was a movie based on it a couple of years ago with Frances McDormand. Yeah, good movie. So, but those people, I find them extremely interesting. And also there are some Homelessness is associated with religious practices, like the Buddha preached homelessness, yes. And in Islam, Hajis making the Hajj to Mecca don't sleep under a roof during the Hajj. Jesus was homeless. So we want to make sure that we don't pathologize, everyone who decides not to live inside. However, there are two, and those folks don't come for therapy, but there are two categories, I guess. So whom do we usually treat? First, there are people who resort to homelessness as a conscious defense against breakdown, a deliberate decision. Consider the victim of intimate partner violence, who may fear that leaving is the only way to avoid suicide, homicide, or going mad. Same is true for the young person told by family that sexual nonconformity means eternal damnation. Usually the first stop is a friend's home, but when friends run out, you can end up on the street. All right, the second group, homelessness can be an unconscious, not a deliberate defense, but an unconscious defense against the breakdown that already occurred in infancy or childhood when it could not be remembered. This one is trickier. These individuals often carry a diagnosis of psychosis. So living both indoors or outdoors feels fraught with danger, hence the occupation of the threshold in the form of doorways by many. Our colleague Gabrielle Brown writes about her work with such adults in her book, Psychoanalytic Thinking on the Unhoused Mind. It's a wonderful book available on Amazon, but the unhoused mind is a good way to think about folks who are not only unhoused in body. A poem by the Somali poet Warshan Shire captures something essential. Joanna, could we have another slide, please? It's a very powerful poem. I will read. So Shire writes, "No one leaves home unless home is the mouth of a shark. No one leaves home until home is a sweaty voice in your ear saying, 'Leave, run away from me now.' I don't know what I've become, but I know that anywhere is safer than here." Okay, moving on. Thanks. So we can see each other. So the IFA accepts therapists of any analytic background, any orientation, but we seem to evoke the name most often of Donald Winnicott. Now, some of you have been reading him for years, and I understand not everybody is steeped in theory, so here's a bit of background. Donald Winnicott was a British pediatrician turned psychoanalyst. He died in 1971. He's probably the most beloved psychoanalyst of any generation. He's admired not only because he treated children made homeless by the bombing of London in the Second World War, but also because he humanized the field generally. The things he emphasized, emotional attunement, the holding environment, and play, the importance of play, are things that had been associated for centuries with women and women's work, and hence socially devalued. So Winnicott also taught us about the need to constantly monitor our countertransference, our own feelings about the patient, and even about trying to tolerate negative emotions, including hate in the countertransference. We have inevitably these tumultuous emotions when we're in a clinical hour, and we do best neither to act upon them nor to disavow them, because it just comes back sideways. But we are mindful, again, to use that Buddhist word, we're mindful of those feelings. We may ask, why today do I feel so frustrated or bored or turned on by this patient? And then we set the feelings aside. Winnicott was a great influence on the school of thought that emerged in the 1980s called relational psychoanalysis. What's different about us? Relational analysts try and pay very keen attention to trauma, as well as to race, gender, and class. In general, our analytic stance is one of, quote, being with, not doing to. And that comes right from Winnicott. We are witnesses. We seek to offer a holding environment for our patients and their pain. Now, a good introduction, if you haven't read Winnicott, and he's, not a little poetic. Some people find him dense, others find him clear, but a very nice introduction is a book by Alison Bechdel. So if we could have the next slide, please, so you can keep this book jacket in mind. I don't know if there are any Bechdel fans. She wrote a book called Fun Home. And this one is called, do we have it? Are You My Mother? Yeah, here it comes. Are You My Mother is, it's called a comic drama. So Allison was in psychoanalysis herself and on the couch kind of thing. And not in the mental health field at all. You know, she was a cartoonist and then a writer, and decided that she was really interested in analysis and, quote, fell in love with the work of Winnicott. And so if you look at the table of contents, the title of every chapter is a Winnicott idea, like true and false self, impingement, use of an object, that kind of thing. And so when I teach theory at the University of Penn in the psychiatry department, I use this book along with Winnicott's texts. Okay, thanks. So let's move on to the question of the first home. Well, the first home any of us inhabits is the mother's body. Ideally, that's the time when all our needs are met, and future homes that we build lean on that original template of security. But what if the pregnant mother was hungry, psychotic, or being punched in the stomach? In that case, the first home was more like a chamber of horrors, and future homes, even enclosures, will reverberate with primitive agonies. Thinking with Winnicott, our goal, as I said, is to provide that's an emotional holding environment, while being mindful not to create impingements, that another word of his, by getting too close or demanding too much of the patient. Indeed, trying to help any traumatized person can be like trying to hug somebody with a sunburn. You know, I'm sure you've discovered. And this is something my group learned early on. The original plan was for staff to call me when someone asked for treatment. Then I would locate a therapist in the group who was available and pass on the information. Well, this resulted in a lot of no-shows. To ask someone who's begun to feel safe indoors to go scout out the office of someone they didn't know just felt like it was an impingement. So I switched to asking our therapists to meet with prospective patients on site. And that's a lot to ask, because it means you can't see a patient before, during, or after that hour. But if they would go to the housing agency, and staff was very happy to show us an empty office that we could use, and then see the patient there and wait until the patient was ready to make the change to our private office. You know, and so the patient would eventually say, well, where's your office? Who gets to go there? And so I would say, it's on 43rd Street. Would you know, can you walk there? Would you know which bus? And then, you know, we sort of get ready. And it has worked very well. I also use some concepts that are well outside the tradition of Winnicott or the relational tradition. For example, from the French analyst Jacques Lacan and his followers. Jacques Lacan respected Winnicott, I think, but he noticed that a lot of American and British analysts seem to have forgotten about the importance of language, of names, and other signifiers in the unconscious that Freud had taught us were so important. So if you were in a Lacanian analysis, you might well be asked to talk about your own names, and especially in the preliminary sessions. So I have used this with all my patients, indoors, outdoors, everybody, asking them to reflect on their own first, middle, last names, nicknames, aliases, you know, and to good effect. With my patients who have been sleeping rough, I find they may not know or remember much of their history or be willing to discuss it. However, everyone will talk about their names. Sometimes we do this even in the outreach van. So I might say to somebody in my office, you have a very interesting name. Can you tell me something about it? Patient. My mom says she named me after an angel in the Bible because I look like an angel. Therapist. What's it like being named after an angel? Patient. I like it because angels have special powers and I do too. Therapist, such as? And then we talk about special powers. You know? So therapist, what about the rest of your name? Patient. I like my middle name because it's like my favorite singer. I always wanted to be in a band. My last name I don't like. It's my dad's, and he did the wrong thing. He walked out on mom and us 6 kids. So audience, you get the idea. My point is that non-intrusively, one has elicited enough material for 5-10 sessions right there. It feels playful, but can go into intimate issues. And those words, letters, initials are very commanding in the unconscious. We know that intuitively. So something else I have found useful with patients and not unrelated to names and language is dream work. And to be honest, I worry this is something that is no longer valued or taught to therapists. I teach the seminar on dreams both at Penn and at my institute, the IRPP. And it's something candidates will continue to tell me is useful only with highly educated people, who majored in English and like to no. So not necessarily so. Anyway, so I started using dream work in 1981 when I was doing family therapy with West Philadelphia families. And they taught me that you don't have to be rich to afford an unconscious. So before we stop today, I'm going to offer one example of a dream. So we should pull up the last slide then. And I'll say, for obvious reasons, I can't give a full case history, but I'm just going to tell you that this patient who I will use, who I will call her Arnell, pseudonym, had spent some time sleeping rough and in shelters due to, let's say, toxic home environments. So in the first 6 months of our work, she dreamed the following. I am walking on Walnut Street, and there's this woman standing outside holding a tray of stuff. You know how sometimes outside the Starbucks, they'll have little small cups of coffee and whatnot as a free taste? It was like that. So there's this lady, sort of look like you, come to think of it, right there on Walnut between 17 and 18. Yeah, I see it bright as day. She's holding these cups, and on top of each cup is a small paper lunch bag. I try to cross the street to get one, but the light stays red. Then I try to cross, but the bus is in the way. Then the light changes, but then I don't even know if she's there or not, and I just feel very frustrated. So therapist says, did it wake you up? Arnell says, yes. Therapist, what happened during the day of the dream? Arnell, I can't remember really, just an ordinary day, but we had a beautiful carrot cake at lunch. Therapist, I am walking. So I use the classical relational method, which is the method comes straight out of chapter 2 of Freud's interpretation of dreams, but I integrate it into a more relational treatment. So she says, ordinary day. Oh yeah, okay. What comes to mind about Walnut Street and the woman? She says, it's like when you get those free samples. I like that, especially on days I got no money. Therapist, I'm just repeating now. I'm parsing every phrase in her dreams. So there's this lady, looks like me. What comes to mind? Arnell, she had dark hair with glasses like yours. Therapist, between 17 and 18. What comes to mind? Can we scroll? Nothing. I don't know. Therapist, well, tell me about you between age 17 and 18. That was the first time I was homeless. That's deep. Like the first night you stay in the park and it's 10 o'clock, 11, finally 12 o'clock, freezing. You realize you'll be sitting in that same spot till the sun come up. Therapist, you were so young. That sounds incredibly sad, frightening, lonely. Arnell, yes, it's the loneliness more than anything. I say, take your time. I'm so sorry you had to go through that. I want to know what it was like for you. If you want to share it. And then she speaks in detail about the hunger, the fear. Do you want to keep working on the dream? She says, sure. My mother used to pack lunches in a sack every day. Well, not that small, but it seemed my brother always got more. The woman was standing in front of that store on Walnut that sells handbags and suitcases, whatnot, right at 18th. I can picture this store, big sign, but not the name of it. What is the name of that store? So in the countertransference, I feel I'm the person holding the tray of things, good things she needs. So perhaps I'll offer the name of the store and see what happens. So I say, because I know which store she means, is that store called To Me, T-U-M-I. She says, yeah, that's it. Scroll. Where'd it go? Okay. She says, to me, she gets the pun. That is so nice. And I say, maybe if there had been somebody there for you between 17 and 18, someone offering what you need, your life would have been easier. She says, yes, I see. Where were you when I needed you then? I say, I do wish we had met. And she talks now more about her mother's death. I say, in the dream, you can't get to the woman with good stuff. There is an obstacle. I wonder if you feel I'm not accessible in some way, or you could lose me too. She says, no, I don't worry about that. You mean how Miss Kathy, staff person, just left? No, they brought in a big carrot cake to say goodbye, but that don't bother me. Seemed like everybody good leaves though. I said, how does that feel? Arnell says, terrible. Don't feel good, but like I say, get used to it. I said, Arnell, how would it feel if I said I intend to be here, as long as you need me? She said, oh yeah? Well, that would feel good. That would feel real good. Okay. End of slide. So wrapping up now, we were able to use that dream to help her verbalize those fears and clarify our relationship. The dream demonstrates also the use of numbers. Again, straight out of Freud. First, you say what comes to mind. The person may say 17 is my lucky number, or, there are 9 people in my family board. If they have no associations, you assume that it's the dreamer's age. That's classical, okay? And boy, does it work. So anyway, it brought up also the feelings about her brother, which became important later. Some of our insight for all patients stay for only a few months, and others have barely missed a session in 10 years. They've used the treatment to work through traumas, enter recovery programs, explore sexuality, do wonderful artwork, and get involved in political activism. We are by no means the first or largest group of analysts working with non-traditional patients, and we love exchanging insights with other groups. I'll close now with some lines from the Indian poet Tagore. He was writing in the 1920s. Rabindranath Tagore. Here's the little poem. I slept and dreamed. Life is all joy. I woke and felt. Life is all service. I served, and behold, service was joy. Thank you.
Deborah, thank you so much. It was so wonderful listening to you. I really appreciate that. I also want to thank Michael and Joanna and Deborah for including me in this this afternoon, and it's great to be with all of you. So thank you so much for being here. So I'm going to focus my talk today on some of the work that I've done that sort of crosses over community-based intervention work and clinical work that centers largely around issues of immigration and race. And so those tend to be the areas of my research and practice that I tend to focus on. So I'm going to highlight that, although I think all of this is very connected to what you just presented, Deborah. So hopefully this will make for a good conversation after as well. So as Deborah mentioned, beginning with Freud, psychoanalysts have been concerned with this interaction of context and the psyche. I will say, though, that in many circles, the application of psychoanalysis or psychoanalytic concepts outside of the clinical encounter has tended to be viewed as non-analytic. It's not without its controversy. So do we consider this to be real therapy or real analysis? These questions come up often. And so in some ways, just the question itself creates an artificial dichotomy between the psychic and the social. So the way we talk about these issues really separates the way we think about people and who has access, who ultimately should have access, or what the access to psychoanalytic ideas actually looks like. And particularly around, we think about the pandemic, we had these unexpected ways in which we had virtual access to psychotherapy for many people. However, this shift cannot possibly meet the growing demands for mental health care. To me, it's really clear that psychoanalytic knowledge needs to be accessed beyond the clinic, in addition to psychotherapy itself being made more accessible to different communities, including marginalized communities. There are several folks who've done psychoanalytic work in non-clinical domains. And one of the forerunners of this area in more recent times is Stuart Twemlow and Henry Parents. And what they did was underscore Freud's interest in group psychology, pointing out that the sole psychoanalytic focus on the inner world and then in some ways the ensuing theoretical rigidity within institutional psychoanalysis actually resulted in the marginalization of analysts and others whose work involved the application of psychoanalysis to understanding and addressing social problems. This rigidity, in fact, stands in contrast to Freud's vision, which Deborah has so eloquently described. Freud's vision of psychoanalytic theory as a critical lens into broader social issues. So let me just share a couple of examples of some of the community-based work that's done by analysts. And some of these efforts have really centered on sociocultural trauma and also the lack of affordable access to psychoanalytic psychotherapy. One example is Stuart Twemlow's and his colleagues' work with schools. And this type of work it really aimed to reduce bullying, which was inspired by different social problems in the 1990s, actually, including the Columbine school shooting in 1999 and generally rising violence against young people. Through these community collaborations, Twemlow and his colleagues developed a description of the common elements of psychoanalytic, clinical, and community perspectives, including a focus on developmental perspectives, holding and containment as frameworks of reference. So Winnicott's influence here, the appreciation for the other person's subjectivity, and also respecting different sides of a conflict. More recently, Vomic-Volkin also emphasized a developmental perspective in understanding large group psychology, stating that large group psychology in its own right means making formulations about the conscious and the unconscious shared historical psychological experiences, past and present, that exist within a large group, whether this group has its beginnings in childhood or adulthood. We see, of course, a lot of young people trying to make sense of the current socio-political climate. There's been a report now issued by the Surgeon General on loneliness and the ways in which the polarization within our country and globally, politically, socially, has contributed to this kind of sense of isolation, particularly among young people. In fact, now we have young adults who report greater levels of loneliness as compared to older adults, which is an unusual trend. Actually, it's a new trend. So we see the greatest levels of loneliness in young adults as well as older adults. So this understanding of large group psychology, in my view, is really quite critical for making sense of people's responses to trauma, sociocultural traumas, and movements, similar to how a therapist might understand the influence of a patient's developmental history on conscious and unconscious fantasies or behavioral patterns or symptoms or their relational life. In addition to extending psychoanalytic knowledge to community-level interventions and to the study of collective traumas or large group psychologies, analysts have also examined historical and ongoing racism within institutions. For example, a systemic exploration of the impact of racism on psychoanalysis in the US was initiated by the American Psychoanalytic Association a couple of years ago, and this is known as the Holmes Commission on Racial Equality in American Psychoanalysis. The report that came from this initiative from the commission, which was just published in 2023, provides what I think is a sorely needed recognition of racism, unequal access, and marginalization of people of color within training structures and processes. So to me, this kind of recognition is a first step in a collective healing process within institutions, within the psychoanalytic community in this case, but even more broadly within institutions and training structures, even while the tensions concerning racial, cultural, religious dynamics persist. So Each of these efforts that I've described so far is very much aligned with the social activism of early psychoanalysis in Europe, which Deborah has reviewed. In addition to these efforts, there have also been efforts made within psychoanalysis in relation to understanding sociocultural diversity within the context of psychotherapy. For example, there have been several scholars, many scholars, who've described the importance of the therapist confronting their own feelings of the racial other in order to address cross-racial or similar racial interactions effectively. Emotional insight in psychotherapy within these perspectives lies in the conceptualization of psychotherapy, the therapeutic interaction, as co-constructed by the therapist and the client, the ability to tolerate ambivalence, anxiety, sadness, guilt, and shame as related to broader sociocultural contexts. These perspectives emphasize attachment, separation, and related mourning as essential parts of a person's growth process, where it's not only the client or the patient that is changed, but it's also the therapist that's also transformed in the process of relating with the client or the patient. In my view, psychoanalysis has the potential to provide depth and meaning to various aspects of diversity, such as race, culture, social class, sexual orientation, disability. And the psychoanalytic literature has indeed increasingly recognized the need to attend to social context in the therapeutic dyad. We now have the psychodynamic diagnostic manual, the third version now, which considers context as a part of diagnosis and thinking about diagnosis very differently, actually, than what we see in the DSM, where context is not necessarily considered as an essential part of a person's subjective experience. It's the DSM is far more descriptive rather than a more in-depth look at one's subjectivity, which is part of the psychodynamic diagnostic manual. So in considering these advances in psychoanalysis itself, for me, it's been critical to think about, well, what do we do within the clinic as well as outside the clinic with these with the progress that we have made within psychoanalysis with regard to issues of diversity. And I'll share with you a couple of examples of what I've been grappling with in my own work. The first, which has to do with very early on in my career, this was in the mid-1990s, I worked at the Cambridge Health Alliance in Cambridge, Massachusetts. I live in the Boston area now as well. But I had been an intern, a psychology intern, and a postdoctoral fellow at the Cambridge Hospital, which it was called that back then. And in the Department of Psychiatry, we had several multicultural, multilingual clinics, outpatient clinics. And Cambridge Hospital was a city hospital that worked with folks who were dealing with probably some of the most severe life circumstances, including homelessness, including severe complex trauma, and poverty, other kinds of issues, substance use, addictions. And we had these different clinics, like there was a Portuguese mental health clinic, a Haitian mental health clinic, a Latinx mental health clinic. And so there was a model for outreach programs that would provide psychotherapy, assessment, psychopharmacological services to specific communities within Cambridge and the greater Boston area. And so I used those as a template to formulate a plan to start a new clinic called the Asian Mental Health Clinic. And one of the things of this era to keep in mind in the 1990s is that the literature within psychoanalysis and psychodynamic theories was just emerging in terms of thinking about multicultural issues, thinking about issues relevant to racial minorities, to immigrants, and so on. And at the same time, there was another emerging literature in multicultural psychology that focused on providing information about larger groups and communities. So for example, we'd start to see literature in the 90s about the experiences of African Americans, the experiences of Mexican Americans, of Chinese Americans, and so on. However, much of that literature tended to speak in broad generalities about these communities or groups within the United States. So there was a very well-known book called Ethnicity and Family Therapy, which was edited by Monica McGoldrick. So you might be familiar with that book. And there was a chapter that was dedicated to different sociocultural groups. And I remember being really excited to see this book, and it was a big improvement from where we had been at that point, in that people of color were actually being talked about and discussed, and the experiences of, BIPOC folks were being examined in some ways, being made more visible. But when I read the chapter that was dedicated to what was called East Indians, and I'm an Indian American, I'm a 1.5 generation immigrant. I came as a child from India to New York, actually. So when I read that chapter, I was pleased with seeing that somebody was talking about our experiences more collectively, but it was really difficult for me to identify with the descriptions of Indian people in that chapter, because it really didn't describe what my inner life was like, what it felt like for me to be an Indian immigrant or a person growing up in the United States of Indian origin. And it really didn't describe the inner life of the people in my family or in my community or those people I knew around me, or of my patients. And so this became a point of interest for me. And then there was another set of literature in multicultural psychology that would emphasize the importance of directive treatments or cognitive behavioral treatments for racial minority people. And this was almost universally applied only to racial minorities. And a large part of this, in my view, was based on stereotypes about us. Like, for example, I would hear, well, Asians like directive therapy because we like to defer to authority. These were the kinds of statements that we would see in the literature. So if we look back on that now, we can imagine that, these are stereotypes actually guiding prescriptions for psychotherapy. And for me, it became a social justice issue, because what it meant was that only some people could get access to different types of therapies, and other people had access to one type of psychotherapy. And this was all under the umbrella of cultural competence. So in the psychoanalytic literature, on the other hand, these issues were not talked about as extensively as they are today. So I started to wonder, is it only white people then who have an unconscious? What about the rest of us? And so, so a lot of my work had to do with trying to figure out, well, how am I going to start a new program that has a psychoanalytic or psychodynamic focus that integrates context? And so much of our work centered around outreach, learning from different communities, talking with people. So we had mental health fairs more broadly, community outreach efforts, like one-on-one conversations with folks in various cultural organizations, health organizations, professional organizations, student organizations, to kind of figure out what are the most important areas of concern. And initially, we started the clinic with 3 clinicians and 2 patients, and we had no idea who would actually come, because there's also a great deal of stigma within our communities in terms of going and seeing a therapist and what that would mean. There's a great deal of fear that the therapist might pathologize me, my family, my culture, my community. Who's going to really understand me? And what does therapy or just talking about my problems going to do anyway? Why is that a modality of healing? It may not be a familiar modality. And people who have tried to go out and seek mental health services, some of them have had really difficult experiences with therapists who might undermine or devalue their cultural background, either very implicitly or explicitly. So these were the kinds of issues that we were tackling in our outreach efforts and our conversations with folks in the community. We thought that we would see clients who were, we imagined a particular demographic, that we imagined that we would see more female identified clients. We thought we might see people who were second generation, maybe they were more familiar with therapy. But in fact, all of our own stereotypes were challenged, because we ended up seeing equal numbers of male and female identified folks. We actually saw more people who were first generation, that is the immigrant generation, than we saw folks who were second generation. So we had, and the program eventually developed into a training site, a full service type of clinic. In addition to that, an offshoot of that development really was around creating dialogues within my particular community, the Indian American community. So one of the things I learned was that it was important to have these intergenerational dialogues around mental health, because it was so taboo to talk about your depression, the violence you might be enduring, sexual abuse, physical abuse, various traumas. And so it was critical that I find some way to create some dialogue about these issues in communities that typically will not talk about these issues in their social interactions with each other. So I started to connect with folks who are involved in religious organizations, cultural organizations, women's groups in the local area, and many of whom kept saying to me, we need to have these conversations. We don't know how to start these conversations. And yet once we did, there was this ability to break the ice with these issues, but also for people to seek help and to be able to connect them with folks in the area that were equipped to work with them as well. The other thing I will say is that one of the key issues that many of the communities struggled with is the invisibility of the racism that they experienced on a day-to-day basis. So if we even think of a very recent example of the pandemic, the invisibility of the anti-Asian aggression and hate, and people standing by and watching elderly people being knocked off, and being spat on. And the silence around racism against Asian Americans is incredible and profound, and has always been the case in the United States. And this is across the board with South Asians, East Asians, Southeast Asians. And so we see this over and over again. And so when I've had these intergenerational dialogues with folks, one of the things that comes up repeatedly is this feeling that our issues are not as significant as other people's issues. There are people getting killed by the police, so why should I complain? Or we have more privilege, or we are seen as having more privilege. And so this idea that of uniformity and the model minority stereotype that is also internalized by people within the community, by the families. And David Eng has written beautifully, and Shin-Yi Han they've written beautifully about this idea, this notion of racial melancholia and the experience of Asian Americans of having to sort of internalize the stereotype of model minority as a way of being visible, but not too visible as to, and as a way of coping with racism. So this has been a large theme that has come up in my work with this community. But I also want to describe to you a couple of things, another project that I had been involved with for a couple of years. And this was a project that I worked on in my time in Washington, D.C. I moved from Cambridge to Washington for a couple of years, and I directed an outreach program there where this was conducted in an after-school program. And I was a coordinator for this outreach project, which was in this middle school located in Southeast Washington, D.C. And The staff and the majority of the students at the middle school are African American. The rest of the students are Latinx or multiracial. The staff at the after-school program had been increasingly concerned about exposure to violence of their students in their neighborhoods. And so many of the staff recognized the stress experienced by the students, particularly a few boys who verbally expressed their anger after witnessing two men mugging a young woman in the neighborhood. And so there was one colleague that I work with. I'm Indian American. My colleague is a white Euro-American woman. And we had arranged a meeting with the staff of the after-school program. So I was at Georgetown. Just for those of you who are familiar with Washington, D.C., there could not be a bigger contrast between being in Georgetown and Southeast D.C., just very different worlds. And very different from me coming from Cambridge to Georgetown, which really felt sort of like being in a kingdom compared to where I was prior to that. So we had an initial meeting with the staff, and my colleague and I learned that this type of incident was very common for many students, the violence, and that traumatic experiences were typically not talked about in the family or at school. The staff hoped to find ways to address the students' exposure to violence at a weekly discussion group focused on health topics. So their idea was to kind of create a health discussion group and also to require the students to attend. During our meeting, an African-American staff member also expressed concern about the ability of what she described as doctors from a predominantly white institution coming over and wondering how in the world they could possibly relate to the concerns of the school, the students, and the community. And when I heard this particular staff talk about this, I was really moved by her honesty because it couldn't have been hard to just put it out there. And at the same time, I felt that she didn't actually notice my race or ethnicity. So it was sort of like, put together, aligned with whiteness because of, coming from where I was coming from. And so it was as though she was solely responding to my white colleague, who was silent, by the way, throughout most of the meeting. And I acknowledged to the staff that my institution is predominantly white, and I asked them to tell us more about what their concerns were. And a different staff stated, well, we really wanted to make sure that you all understand the community here and what our kids go through and what's actually realistic for them. Other people in the group agreed, and it was clear that the staff were understandably protective of the kids and cautious about any negative outside influence that would further traumatize them or stress them out. The staff's concerns reflected prior experiences with healthcare professionals who disappointed their community. One example of this was raised by a person who said, I'm worried about how many of our boys have this label of ADHD, and the parents are just told to give them medicine. Some of these boys just need someone to talk to, not all of these drugs, but this is what the doctors tell them to do. So the staff, as they talked about their concerns, I was aware that many of the staff and the students had previously experienced institutional racism, and then the cultural mistrust towards me, possibly because of the concern that I might have also internalized the oppressive culture of these institutions. And so towards the end of the meeting, this first meeting, we thanked everybody for the discussion and we went on our way. We said, we'll figure out what our plan might be that we can offer back to you. So while driving back to our office, I asked my colleague why she had remained so silent during the meeting. And she said she was overwhelmed by a sense of sadness and guilt and worried that she would enact the situation that the staff and she feared by taking over the meeting by talking. She chose to stay silent to cope with feeling simultaneously like an outsider and an oppressor. And I told her that, interestingly, I felt like an outsider since my race and ethnicity were treated as not as either invisible or irrelevant, and that racial difference had been conceptualized around black-white lines, as they typically are in American society. So my colleague said that she felt surprised by my reaction and that she saw me as the insider because of my Indian background. So indeed, the consultants here had felt othered, and at the same time, we wondered whether we had othered the staff in some way. We were also aware of being outside of the comfort zone of our offices, potentially imposing ourselves on this school. So here we are in this sort of taking in this broader US dynamics around race into this effort. In our second meeting, towards the end of our second meeting, one of the staff members asked me where I was from. And I said I was born in India and I grew up primarily in the US. And she said she knew I wasn't from the US. And I responded saying, well, I'm Indian American. And I said, where did you grow up? And then she told me that she had been raised in the local area. And in the coming weeks, during the periods between our meetings with the staff, I wondered if I should interpret what I repeatedly experienced as sort of being the other because of my non-Black and non-white racial status. I also wondered for whom and at what point in an interpretation of racial dynamics would be experienced as helpful. This insider-outsider dynamic that was apparent from the beginning of our interactions conflicted with my own wish to belong and be accepted as a credible professional who could be effective with this program. In the third meeting with the staff, we started to talk about this. We started to engage in a discussion about the students' self-care in the context of violence exposure. And several staff members actually reported that they worried about the students' physical health as much as their emotional health. So, and in fact, some students mostly depended on fast food restaurants for their meals, and other students ate only one meal per day at school. The staff then expressed that many of the students didn't have access to annual physical exams because of their parents' work hours or unavailability. And one person said, the students are sometimes treated like they're adults, like they're supposed to feed themselves, take care of their bodies, and sometimes nobody's there to protect them. As our discussion progressed, we started to talk about the possibility of developing discussion groups after school focused on physical stress related to the exposure to violence in the neighborhood. Specifically, we planned a discussion with the students about how being exposed to violence can be stressful to the body and strategies to cope with the stress. My colleague and I asked the staff to tell us about their perceptions of students' attitudes towards nutrition. And most of the staff told us that the students had very little exposure to healthy eating. And my colleague suggested that we discuss healthy eating habits with the students. And I joined by stating that it might be helpful to provide some kind of handouts or some information about healthy meals. When we ended the meeting, I realized that the staff hadn't actually responded explicitly to our suggestions and also, in fact, my colleague and I hadn't considered how this approach would be experienced by the staff or the students. I also recognized that I was disappointed in myself for not thinking through the social contextual implications of this nutrition education. And in retrospect, I think that joining my colleague in simplifying or neglecting the social context of the intervention was in part a reflection of my own wish to identify with someone, my colleague, who had been more emotionally accessible to me at that time. Up until this point, I hadn't been successful in my efforts to connect with the program staff and had perhaps resigned to the idea that my help was not going to be accepted. So we had 3 remaining meetings before this, the initial student workshop, and I had asked the staff in our next meeting to describe their reactions to our suggestions from the previous meeting. While some staff seemed reluctant to share their reactions, others stated that they didn't know how the students would be able to relate to this eating plan or this nutrition plan that assumes that people have adequate resources and access to markets and restaurants that sell certain types of food. One person said, there's no Subway here, you know. So I then commented that you probably feel like our idea raises some important questions, like, is this plan even realistic? Or how might someone who doesn't live here understand what it's like to be here? And so, and several staff then said that they wanted the intervention to be productive, and providing this type of information is probably not relevant to the students. I agreed with them. They also reluctantly shared that there was a difference in their reality versus the context where our suggestions were rooted. which were more relevant to a place with resources in middle-class neighborhoods. So we started to talk more openly at this point about our differences in social class and race. Later in the discussion, I told the group that I too was feeling alienated and disempowered in certain contexts, predominantly white institutions, and by people who were not familiar with my Indian ethnicity. Many staff then expressed that they appreciated hearing about my experience, and they had indeed assumed that I would not be able to relate to their context because of my privileged status as a professional. They also talked about how their interactions with some Indian people whom they experienced as acting more white than people of color. And I responded by sharing that race indeed held an ambivalent position with many Asian Indians and with immigrants more broadly, and that sometimes I feel like I'm searching for a place of belonging, since race is often seen along Black-white lines in the United States. These moments in the meetings, in our meetings, marked an important shift in how my colleague and I connected with the staff. Everyone in the room in these moments seemed more relaxed with each other, breathing a sigh of relief, as though we all felt a little bit safer with each other. I came to realize that not only was this discussion critical for creating this general feeling of safety, but also for moving towards a conversation about exposure to violence in the community, an experience that was shared by the students and the staff. In the last two meetings, the staff started to share some of their own experiences of witnessing and being victimized by community violence. They talked about how they often felt alone, isolated, with few resources to access the help that they needed for themselves. To us, it became clear that the staff's ability to connect with the students' experiences with community violence would be an important part of this intervention, this after-school intervention. We started to talk in depth about how the staff could potentially talk about some of their own experiences early on in these discussion groups with the students as a way of helping to validate the students' experiences and to collaborate with them to develop strategies that are culturally and contextually grounded. So I wanted to share this example with you as a way to illustrate the complexity of dynamics in doing this work and how psychoanalytic approaches can be helpful in community-based work that Deborah and I have been referencing so far. So I want to thank you for listening.
Interrupted.